I'll be presenting on the second case. So this is a 60-year-old gentleman. He was previously diagnosed with follicular lymphoma, stage 4. The diagnosis is established on a lymph node as well as bone marrow involvement. That time, no cytogenetic test was done, but patient completed 6 cycles of RCVP and rituximab maintenance, and then his count actually normalized after the RCVP, and then since 2015 until early this year, patient was followed up like annually or biannually with the almost normal FBC count. However, early this 2023, patient developed pancytopenia with constitutional symptoms, lymph node as well as hepatomegaly and splenomegaly. So this is the full blood count. You can see there's a neutropenia, very severe anemia, and as well as thrombocytopenia with leukoerythroblastic as well here. So I'll show you the peripheral blood film, bone marrow flow, followed by trophine and cytogenetic for this 2023 result. So the picture I'm showing you here is the peripheral blood film. Okay, let's see. Actually, I want to show you this. Looks like a lymphocyte, but it's a little bit clefted. This is not really very nice one, but I try to find one good for you.
It's a pancytopenic picture.
Yeah, pancytopenia with NRBC minus.
Oh, leukoerythroblastic also.
Yep.
Okay. So in other words, there is circulating follicular cells, that is what you're trying to tell us.
There are quite a number of lymphocytes, and then very occasional you see some cells like this. They have a cleft in the middle of their nucleus, a little bit like that.
Yeah, I don't think we can see in the internet transmission. Not so good,
because
not so high resolution.
Because we are using a different place for this projection. The quality of this image projection from microscope here is not as nice as we do in our bone marrow lab.
Yeah. Usually optics is quite good under microscope, but once transmitted in the internet, they have lost the resolution, cannot see that well. It's okay. You tell us lah.
Yeah, pretty much that's the blood film. So it's a pancytopenia with leukoerythroblastic picture, lymphocytosis, and some lymphocyte appears clefted. So this is a bone marrow aspirate. There's no fragment. And then, but what we get here is like, you see, there are ruptured cell here and there. And then predominantly lymphocyte. And then you consistently see the lymphocyte with this indentation, like clefting a little bit here, some here. That is quite consistent with the.
You think you can throw some light? So you adjust more light, see whether we can appreciate the clefted nature of the cells. We can see a little bit of indentation, but I wonder if you said, let's say you throw intense light through the nucleus, whether we can appreciate it into the internet, the clefted nature of the cells. stronger light? Possible or not?
Quite, I don't know.
Not possible.
I try to play
Not
with the
possible.
white balance, but it's still the same. But
Yeah.
if you can see
Yep.
the cells here and here, you can see a little bit of going inside the nucleus margin.
Suggestion, but cannot see.
Yeah, that's the
Okay, it's all right. Don't worry. Yeah.
that's the downside of having it projected digitally. You need to have very good but something like this lah.
Yeah. Yeah, there's a little bit of indentation we can see lah. So the cells are variable, variable in size. Some small, some
Yeah,
intermediate.
mostly
Yeah, some
small to some medium,
Okay.
but no large cells.
Okay.
So after this, I'll show you the flow first. This because despite it being aparticulate, but we still see most of the cell are lymphocyte, and then we saw those abnormal looking clefted cells. We think we should be able to catch the lymphoma cell in the flow. So the 45 side scatter looks like diluted sample, like you see lymphocyte, monocyte, glands. And then when we analyze the lymphocyte population, you see here, initially I thought I would be getting a lot of B cells, but I'm kind of a little bit surprised. Actually, most of the lymphocyte are actually the reactive T cell and with some mixture of NK cells. But within these T cells, you have CD4 and CD8 cells. So my interest is the B cell, so I'll zoom in to look at the B cell. But you see here, the B lymphocyte only constitute about 11% from the lymphocyte
This
population.
is the bone marrow.
This is the aparticulate aspirate. So it's a little bit, so it's actually not truly representative, but diluted. Yeah, but just bear in mind the percentage. So later we can compare what we see on the Trefine and what we see on this flow. But despite the fact that it's so diluted, we still can gather some information from the flow. So my interest, we gated the CD19 positive B cells. They are also 20 positive. One would expect if the follicular lymphoma cell is there, you would expect CD10 to be there, but this is looks like the CD10 is negative in this B cell. And then we'll go back to this later on. And then we further analyze the B cells using the kappa lambda. Even though you still see kappa lambda, but the ratio actually is a little bit abnormal. Because I would use like 0.75 to 3.5 for the kappa lambda ratio. So this one is like 4 point something.
Slight excess of kappa lah.
Yep. And then my suspicion that there are a mixture of residual normal B cells. I suspect some of the follicular cell is also hiding in this kappa region. And then it is confirmed with this, when I look at the 22, you can see there are two populations of B cell with different intensity of CD22.
Yeah.
So the CD22 dim B cells is a little bit fishy or suspicious. And then this constitute about 50% of the B cells. And then if I compare with this ratio, actually kind of like correlate. So in these B cells, you still get some residual B that is polyclonal, and then some of the follicular lymphoma cell, they are actually aberrantly dim for 22, are only expressing kappa. That's why the kappa lambda ratio is near to 5.
Yeah, so you catered out a population. Actually, it's not dim, you know. The intensity is 10 to about 3. It's intermediate. Lah. Of course, your 10 to about 4 is very strong. Lah.
Yeah.
Yeah. But that one, of course, is probably a reactive one, a normal B cells. Yeah. Okay.
But the thing is like, one you might say is like, why the 10 is negative? But just bear in mind the follicular lymphoma, when it's in leukemic phase, be it in blood or the trephine, can be frequently negative compared to what you will get in the lymph node biopsy. So before this, I'll show you the trephine. How come I cannot go back in this PowerPoint? I cannot go back to the previous slide. Never mind. Why is it so wide?
You have to adjust your lighting again. Sorry. This time I adjusted.
Is it better now?
Yes, definitely better.
Yeah. So this is the trephine. So it's so different from what you see in the flow and the aspirate. So you cannot get anything out because it's packed with all these overall looks like small lymphoid cells, because the marrow
that's
is so
one
packed.
Possibility. But the other possibility, you have to see whether I don't know whether you're going to do a reticulin on this one. Yeah. Oh, okay. The other one, of course, is thinking of fibrosis.
Yeah.
Okay. Really packed, huh?
Yeah. So very blue color because most of them are these small mononuclear or lymphoid cell or lymphocyte looking cells.
Yeah.
So this is CD20. So majority of the cells are CD20 positive.
Okay.
And then generally still small, only very minor population looks a little bit more medium, but we don't really see that much of a large cells that or the bizarre looking cell. This is CD3 just for comparison of the number of B and the T cells. So reasonably still quite a number of reactive T cells in the background, but you can compare the B actually is so much more denser compared to this T cell, but quite a number of T cells in the background as well. This is a CD10. It's variably staining up for CD10. I would say very weak and some even looks like negative. Because if you can recall back the intensity with CD20, this CD10 is only like very little of the cell. Some at this large area looks completely negative, and then only a little bit of the cells are actually.
What are they staining? I can see a lot of other staining. Can't see very clearly. What other cells they are staining? Are they staining cells or blood vessels?
I think they are the cells because it's a cytoplasmic staining. Some are weakly positive here, but a lot of the cells are negative.
Is there those positive cells? Does it show an aggregate pattern? Does it show like a cluster like that? I couldn't see that well in in the internet pictures. What about your light microscopy? Do you think all these CD10 cells actually appear as a cluster?
Not really in aggregate, actually.
That seems to show a small cluster here and there. Not sure. Yeah. Better visualize under the microscope.
Obvious. But basically, just to show the positivity for CD10 is much lesser than compared with the number of CD20 positive B cells. And then this is a BCL2. So the BCL2 intensity is corresponding to the CD20, and then it's very bright and showing up positivity in almost all of the B cells.
Yep. Correspond.
And then this is a Ki67. But I just remember the number of the T cells. So I think these are just mostly from the reactive T cells. So the B cells actually mostly are low Ki67.
Yeah,
so just
it's like more like a scattering pattern corresponding to the T cell rather than the B aggregates. Okay.
Yeah. So far, like from the flow TrefFine, we are quite happy that this is consistent with maybe a relapse of underlying follicular lymphoma. But when we do the cytogenetic, and then we find some atypical findings, because we were hoping to get the 1418, which is the BCL2 with IGH. But in here, we actually can't really see. Although this 18 looks a little bit shorter, but I was told that they actually have the band that they're supposed to have. But what we found here is actually the 8 is shorter, and then the 14 is longer. So it looks like instead of the IGH BCL2, we are seeing what here could be a MYC with IGH.
Yeah. So
something then we were very puzzled, because like 814, if you have a 8 with 14, which you usually see in Burkitt lymphoma or DLBCL, or most of it is very aggressive kind of lymphoma or leukemia. But this case, we cannot find the 14, 18, but it looks like something is happening with the 8 and 14. At the same time, you also find some additional, like a complex thing, like the 16 looks, the long arm of 16 looks shorter, and then we have this marker chromosome here. We speculate it could be a combination of some material from 8 with 16 probably. So to confirm our suspicion of this got a 14-18 translocation, then we
The
proceed.
14 translocation, is it every metaphase they examine all consistent, or some of them may be different?
Pardon?
Any idea whether let's say they examine 30 metaphases, all of them are actually 814?
No, we only find like out of 20, we get about 2 to 3 cells with the majority of them still are normal metaphase. Only a few of them have that chromosomal abnormalities.
Okay.
How come I cannot go back? So not all the metaphase, we have most of them of the metaphase are normal, but about 2 to 3 to 4 of the metaphase is with this kind of abnormalities.
Okay.
So we did first we did a IGH break apart. So this is a break apart probe. So the red color paint the constant region, and then the green color paint the variable region. So in normal, you should get they should be fused or combined in normal. So you have one normal IGH and then another one is broken apart. So this is the abnormal signal here. So one of the IGH is break apart. And then we continue with FISH fusion probe for 814 in about 13% of the cells. So this is a tricolor fusion probe. This blue color or the aqua is painting the centromere of 8. And then the red color is for the mid region. The green color is for IGH. So before I go to this patient result, then let me just bring you to a typical findings first. What you will get in a, let's say, a Burkitt lymphoma. So if this is a balanced translocation, you should be getting 2 aqua, 1 red, 1 green, and 2 fusion. This is the finding that you will get, or the typical finding you will get in reciprocal or balanced translocation. However, in this patient, we still see 2 aqua, and then we see 1 fused signal. This represents the translocation 814. But instead of having 2 fused signal, we have one that looks like a near fuse to us, and then you have additional mixed signal here as well. So it looks like it seems there is a translocation 814, but the findings are a little bit atypical.
Yeah.
So the point of discussion for this case is mainly on the cytogenetic findings. So follicular lymphoma is usually characterized by translocation 14-18, which is your IGH with BCL2. You can demonstrate this translocation in up to 90% of follicular lymphoma cases. And then it's an indolent neoplasm from Gemina Center, usually present with lymph node, bone marrow involvement up to 70% at diagnosis, and with the hepato and splenomegaly. The classical immunophenotypic profile, they should be positive for CD10, BCL6. These are the Gemina Center marker, and BCL2 positive. Morphologically, with this classically is with the cleaved nuclei. On the other hand, for translocation 814, which is mixed with IGH, commonly seen in aggressive kind of disease in Burkitt lymphoma, DLBCL, some in ALL, especially a B and T also. So this case, because the diagnosis of follicular lymphoma from immunophenotypic and as well as flow cytometry and morphology looks like follicular lymphoma. But why this follicular lymphoma does not have 14-18, but instead it has 8-14, and then it raised the suspicions like, can follicular lymphoma have 8-14 translocation? Or if you have a MYC translocation, could this be actually a sign of a transformation to DLBCL or high-grade lymphoma? So these are the readings that we do. Apparently, people have reported follicular lymphoma with 8-14 translocation. And if you look back, the WHO, there's one sentence talking about this follicular lymphoma with 8-14. What they found is actually the break apart from the 8 and 14 are not exactly the same like what you get in Burkitt lymphoma. They seems to be a little bit more distal to the usual MYC break apart rearrange point. And then they actually demonstrated the MYC is not rearranged from all this case series that they presented. So if you look at here, the chromosome 8 of our FISH probe paints this whole region of 8q24. So the MYC is here. From this paper, they found that the translocation that happens in the follicular lymphoma for 8-14 actually is more distally involving this PVT1 region. So the cases they presented are all indolent, and then even with 8-14 translocation, but did not demonstrate rearrangement of the MYC. So all of the case series presented are actually very low grade and indolent. So the take-home message from this case would be refreshment is follicular lymphoma. Up to 90% will have 14-18. And then when you are looking for the flow or trephine, bear in mind the CD10 can be frequently negative in your flow and trephine. They will not come out as nicely as you expect to see in lymph node biopsy. And then for 8-14 translocation, commonly seen in high-grade lymphoma, like Burkitt, DLBCL, or ALL. Follicular lymphoma with translocation 8-14 are very rare. And then if this is truly the case, the 8-14 actually falls at the breakpoint outside of normally affected in Burkitt lymphoma and DLBCL. So without the MYC dysregulation, so the follicular lymphoma with translocation 8-14 are still indolent. However, in this case, when I want to prepare for this case, I look back. This patient actually presented after the marrow, actually presented with quite aggressive kind of disease. So it also leaves me thinking like, if we are seeing a follicular lymphoma now with a MYC or 8-14, should we also be suspecting this might be a clonal evolution from the underlying follicular lymphoma clones? But the point against it is like if I just based on the trephine, at that time, the marrow done was like 6 months ago. At the time, the Ki-67 are still all very low. And then I don't really see big cells or DLBCL cell in my marrow yet.
Okay.
With that, thank you. And then we welcome any question or discussion.
So do we have any cytogenetic data in the original diagnosis?
No, that's a good question because I think because the patient was diagnosed in 2012, I think maybe that time our lab don't even have a cytogenetic service. So I feel like maybe next time if the resources are there, I think all these lymphoma cases or CML cases, we should perform cytogenetic of fish to confirm at that level. So we can compare if this is truly a clonal evolution. Because I can't be sure is the 814 happens from the very beginning or actually is actually something new.
I think there's a note from Dr. Lee Bi-san. Is the lymph node sample available in the archive?
I think it should be because it is
so
done here.
Possibly you can actually do the lymph node archive sample for you to determine the cytogenetics of it or even the fish.
We can try actually.
Yeah, so that will help you to solve the problem whether this is actually a evolution of the original low-grade follicular to possibly a high-grade one, although you don't see the big cells lah.
Yeah, right? the problem is also I think because follicular lymphoma sometimes you get one side you get low grade, the other side you might get high grade. So I think we still need the lymph node biopsy because who knows the lymph node actually are all DLBCL cells.
Yeah, so that is one point to possibly to help you to clarify this case, because that's what you want to know, whether it's an evolution, it's a transformation in the low-grade follicular to now possibly a high-grade. The other thing is, of course, you look at the EC14 translocation. What do the cytogenetics say? Do you think this one is actually belong to the usual high-grade lymphoma kind of EC14 translocation, or it is different?
Maybe I need to ask for help from Mazia.
I wonder whether, I think that's a very relevant question to be posed, to see whether this is an atypical EC14, which may fit into a unique subtype of follicular with an EC14 translocation, or is it actually a transformation to the typical EC14? Yeah, and anybody can comment on this. Yes. Can we hear the comment?
Can't tell whether based on the signal alone, but this is like obviously not a classical EC14 reciprocal translocation where you can see two fusion cells.
Yeah.
But like phosphate, so maybe the break at the chromosome 14, the MYC cell, can tell whether there will be any dysregulation of the gene or not. So in this case, I'm not so sure.
Okay, so here is thinking whether there is a deregulation. Is there any way to investigate the deregulation of the MYC gene? You know, the typical translocation EC14, the 1418, right, is your BCL2, what we call BCL2 IGH, isn't it? Yeah. Whereas this one is the MYC portion and the involvement of MYC portion and the immunoglobulin gene, heavy change genes translocation. So the question is actually whether that one, are you able to visualize whether this is the typical EC14 translocation in a diffuse large cell lymphoma or a Burkitt's lymphoma, or is it actually atypical at all? What do you think?
I think it looks atypical because by right, if you have a in bucket, you should get 2 fusion.
Okay. So your fish result actually suggests that it's not the typical egg 14 translocation type lah, the appearance.
Yeah.
The fish kind of results.
then-
Yes.
Yeah, and then from what I read, the other clues you can get is like in bucket or then the translocation 814, it should be a balanced translocation, like simple
Yep.
reciprocal, that you get 2 fusion signal from your fish. And then 2 is, it should be the translocation 814 should be the primary cytogenetic findings. Like it should be, usually it's a simple cytogenetic findings compared to this one, which is a little bit complex. Like beside this atypical translocation, you also see extra marker chromosome. This, we suspect this might be actually containing the extra rate signal from the egg. And you also get abnormal 16. We think this 16 actually translocated here as well. Other than that, also the 22 also looks a little bit abnormal. So you have a complex cytogenetic finding, and then with an atypical 814. So it seems like this might be actually not really the primary possible, like that you get in Burkitt lymphoma.
So, okay, so it's more suggestive saying that it's more like a evolution, a transformation, giving rise to a complex karyotype. Yeah. It's more suggestive that it could be actually a transformation of the original follicular lymphoma to a more aggressive type of lymphoma. Okay. So the question now, the other thing, of course, whether this complex karyotype fit into chemotherapy karyotype or not. You know, the patient have actually received chemotherapy, isn't it? So the question now is, some of the changes of the cytogenetic, does it fit into the, you know, even if people receiving chemotherapy subsequently, they may actually changes in their karyotypic features, and that actually predispose them to, you know, a lymphoma, a high-grade lymphoma transformation. So maybe there's also an element to be thought of also lah. Okay, so let's open the case to comment. Any comment from the audience? All right. So okay, if there isn't, so thank you very much, Dr. Poh, for presenting this very interesting case. As usual, sometimes we don't have an answer. We have to go back and look back and perhaps further study in order to have a clearer picture of the, you know, the presentation of the case. So I think thank you very much for all the take-home messages. So if there is no further question or comment, is there any comment for both cases? If not, then we thank both presenters and also the UMMC for hosting this digital morphology session. So we hope to.
Thank you, everyone.
All right.
Bye-bye.
Thank you very much. So we hope to meet again in December. Bye-bye.
The sound, is it from the Zoom message or question or what? I don't know how to open to see the comment. I don't know whether got people.
Record.